In this chapter, we will discuss the multimodal treatment of various cerebrovascular disorders. We will begin by defining different types of multimodal treatment and then discuss specific multimodal management strategies for arteriovenous malformations, dural arteriovenous fistulas, and intracranial aneurysms. The indications for multimodal treatment can be defined as one of the following. First, it can mean the use of multiple complementary treatment modalities to treat a single lesion. Second, it can refer to the use of one modality as primary treatment, while another modality is utilized to treat an associated lesion, for example, a feeding artery aneurysm in the case of an arteriovenous malformation. And finally, it can refer to the use of an alternative modality after failure of a first-line treatment. We will begin by discussing multimodal management strategies for parenchymal AVMs. In general, multimodal strategies for AVM treatment fall into one of the following categories, specifically endovascular embolization combined with microsurgery, endovascular embolization combined with stereotactic radiosurgery, and the combination of stereotactic radiosurgery and microsurgery. Perhaps the most commonly employed multimodal management strategy is endovascular embolization prior to microsurgical AVM resection. The goals of preoperative embolization can include simple reduction in AVM blood flow, the targeting of deep or surgically inaccessible feeding arteries, the treatment of flow-related aneurysms, or some combination thereof. This figure contains images of an unruptured right parietal AVM that was preoperatively embolized with a combination of polyvinyl alcohol particles and onyx liquid embolic agent. When comparing panels A and D, one can see significant reduction in flow to the AVM after embolization, as well as elimination of the nidus underlying the large draining vein, which would have been difficult to access during surgery. The pathologic specimens in panels E and F demonstrate penetration of onyx into the nidal vessels. The main drawback of preoperative endovascular AVM embolization is treatment-related morbidity, which can occur in up to 5% of cases. Specific complications include cerebral infarction secondary to occlusion of vessels supplying normal brain, as well as AVM rupture after embolization. Rupture in this setting is usually due to occlusion of AVM venous outflow pathways, leading to increased intranidal pressure. Furthermore, there is evidence to suggest that preoperative embolization may not significantly reduce the morbidity associated with surgery. Given these limitations, we do not recommend the routine preoperative embolization of AVMs, but only to accomplish a clearly defined goal, most commonly to occlude deep arterial feeders that are relatively inaccessible during surgery. Endovascular embolization is also frequently employed prior to stereotactic radiosurgery. The efficacy of radiosurgery has been shown to decrease proportionately with AVM volume, mainly due to limitations on deliverable radiation dose. As such, endovascular embolization can be used to reduce AVM volume, thus increasing radiosurgical efficacy. Interestingly, multiple large series have suggested a possible association between pre-radiosurgical embolization and reduced AVM obliteration rates after subsequent radiosurgery. The mechanism of this association is unclear and has been postulated to be related to suboptimal targeting, reduction in nidal dose due to absorption of radiation by embolic material, and activation of angiogenic signaling cascades after the endovascular procedure. On the other hand, this association may be spurious and secondary to the fact that AVMs of greater complexity are the ones that require embolization. Importantly, no differences in the rate of AVM rupture during the radiosurgical latency period has been observed for patients treated with or without embolization preceding radiosurgery. An additional interesting association that has been observed is a reduction in the incidence of radiation-related side effects in patients treated with pre-radiosurgical embolization. Radiation-induced cerebral edema is believed to be secondary at least in part to venous stenosis or outright thrombosis. A reduction in arterial inflow by endovascular embolization may increase the tolerance of the surrounding brain to subsequent reductions in venous outflow. An important example of multimodal treatment of AVMs is endovascular embolization of feeding artery or intranidal aneurysms followed by stereotactic radiosurgery. Exclusion of these high-risk lesions obviously reduces the risk of AVM hemorrhage during the latency period before which radiosurgery has taken effect. This figure demonstrates the endovascular coiling of an ophthalmic carotid aneurysm associated with a left frontal arteriovenous malformation. After treatment of the aneurysm, the AVM was treated with radiosurgery and was found to be completely obliterated on follow-up MRA obtained 3 years after treatment, as shown in panel D. It is worth briefly discussing the combined use of stereotactic radiosurgery and microsurgery. Historically, these modalities have been employed as salvage therapies when the other has failed to completely treat the lesion. More recently, however, there have been reports of pre-surgical radiosurgery of AVMs to essentially downgrade the AVM and reduce the morbidity associated with surgery. This is an emerging treatment paradigm that may prove useful for complex lesions. Finally, cystic changes in brain areas previously targeted with radiosurgery is a known late-term adverse event associated with radiosurgery. While often asymptomatic, these cysts can cause symptoms either by mass effect or surrounding cerebral edema. Treatment for these lesions can be with microsurgical resection or simple cyst fenestration. Shown here is a flow diagram depicting the management of parenchymal AVMs. For low-grade unruptured AVMs, we favor microsurgical resection with or without endovascular embolization as a first-line option. However, stereotactic radiosurgery can be considered an equivalent option, particularly for small lesions without angioarchitectural features that increase the risk of near-term rupture, for example, an intranidal aneurysm or venous outflow stenosis. We consider stereotactic radiosurgery to be a first-line option for higher-grade unruptured AVMs, with surgery with or without embolization as a second-line or salvage therapy. For ruptured low-grade AVMs, we consider microsurgical resection to be the first-line option. An alternative strategy is stereotactic radiosurgery after the endovascular treatment of high-risk features that may have been responsible for the hemorrhage, most commonly an intra- or perinatal aneurysm. For higher-grade ruptured AVMs, the risks of surgery must be weighed against the risk of hemorrhage within the latency period of radiosurgery. These remain very challenging lesions to treat. Multimodal treatment strategies have also been employed to treat dural arteriovenous fistulas, usually after failure of endovascular techniques to definitively treat the lesion. Such strategies usually consist of endovascular embolization followed by stereotactic radiosurgery. This treatment paradigm is most commonly employed for high-flow fistulas affecting the transverse or sigmoid sinuses. Particle embolization can be performed to reduce flow through the fistula, which can then be definitively treated with radiosurgery. The use of particles at least 150 micrometers in size greatly reduces the chances of cranial nerve ischemia or inadvertent intracranial embolization during these procedures. Shown here are images from a patient presenting with debilitating pulsatile tinnitus secondary to a high-flow fistula affecting the transverse sigmoid sinuses that was fed by branches of the right external carotid artery. Embolization with onyx had been previously attempted at an outside institution, but was unsuccessful. We elected to initially treat the fistula with particle embolization in order to palliate her symptoms and then proceed with stereotactic radiosurgery. The reduction in flow is believed to increase the efficacy of subsequent radiosurgery. Follow-up angiography shown in panel C and D performed 3 years after treatment demonstrated complete obliteration of the fistula. It is important to note that this treatment strategy is viable only in the absence of concerning angioarchitectural features, mainly retrograde cortical venous drainage. In patients at risk for hemorrhage, we recommend definitive endovascular or surgical treatment as opposed to radiosurgery. Finally, we will briefly discuss the multimodal management of intracranial aneurysms, which is typically necessary after failure of an initial treatment modality to completely obliterate the aneurysms. Alternative examples of multimodal management include the partial coiling of ruptured aneurysms followed by planned definitive clipping at a later date. More recently, partial coiling has been used to temporarily secure ruptured paraclinoid aneurysms, which are subsequently definitively treated with flow diversion. Given the difficulties associated with revision surgery, endovascular treatment of previously clipped recurrent aneurysms is sometimes desired. The endovascular treatment of these aneurysms usually requires adjunctive techniques, most often stent or balloon assistance. Shown here is a previously ruptured dissecting type pica aneurysm that was initially treated with clipping. Follow-up CT angiography obtained several years later showed a recurrence adjacent to the clip, as shown by the black arrow in panel C. The patient was taken for repeat angiography, which confirmed the recurrence, as shown in panel D. The recurrent aneurysm was treated with stent-assisted coiling, as shown in E. Control angiography after embolization demonstrated exclusion of the aneurysm with good filling of the distal pica. Thank you.